Croeso, welcome to this instructional video on the management of epistaxis or nosebleed in the emergency department and on the ward. Causes can be classified as local or systemic. Local causes are iatrogenic, such as nasal sprays or surgery, inflammatory, for example rhinosinusitis, or traumatic. However, idiopathic causes make up the vast majority at 85%. Less obvious are the systemic causes, such as hereditary hemorrhagic telangiectasia or coagulopathies and platelet disorders. Starting a new rotation can be extremely stressful for junior doctors, especially when you are expected to undertake a lot of new procedures. To make things simpler in Swansea Bay, we have a 6-step management algorithm for epistaxis. This can be followed from ABCDE Recess, simple first aid, cautery, as well as nasal packing and surgical intervention. Step 1. ABCDE Recess. As with any hemorrhage or trauma, epistaxis can lead to patients becoming hypovolemic and fatalities are not unheard of. Don't forget to use the ABCDE Recess approach to the patient and ensure they are stable. Airway compromise and breathing difficulties arise with traumatic epistaxis, but also with posterior bleeding. It is important to achieve good IV access in the emergency department before admitting to the ward, as the patient will require samples for a full blood count, urea and electrolytes, liver function tests, and a clotting profile. It may also be necessary to give fluid resuscitation plus or minus blood products. Step 2. Simple first aid. Once you are satisfied that your patient is stable, your priority is then to control the bleeding and maintain the airway. Try to keep the patient as calm as possible. Ask them to sit down and lean forward over a sink or kidney bowl, which keeps the nose above the level of the heart, further aiding to reduce bleeding. Ask the patient to breathe through their mouth and pinch the soft, fleshy part of their nose firmly. This is the standard first aid position, and they should apply this pressure constantly for at least 20 minutes without peaking, after which time they should take a brief pause to assess if the bleeding has stopped. It may be useful to have the patient suck on some ice or place ice packs on the bridge of the nose. Do not let them lie down or lean back, as this encourages blood to flow backwards and potentially enter and obstruct the airway. It is also important to ask the patient not to speak, swallow, cough or sniff, as this may disrupt the clotting process within the nasal cavity and prolong bleeding. They should, however, be encouraged to spit out any blood from the mouth, as it is emetogenic and could lead to vomiting.